Okay.
Hello.
Good afternoon, everybody. Right. We are ready.
Okay, would you like to start your cases?
Okay. So actually, we have two cases of main PCI. All right. Dr. Cho Hyun Lee, Dr. Jo, and our technician, Mr. Zhang here. And okay, you want to introduce case first?
This patient, 78-year-old male, he was admitted for silent ischemia. His chest CT shows significant stenosis left main and mid-LAD, mid-RCA, and very high calcium score over 4,000. Coronary angiography show left main bifurcation disease and significant in proximal mid-LAD with heavy calcification. Next. He has risk factor hypertension and is smoker. Next. In CAS lab, bedside echocardiography normal LV function. Next. Yeah, we'll show you coronary angiogram.
Angiogram? Okay. All right, this is first our diagnostic coronary angiograms. Maybe aerial, caudal view. There are very heavy, fluoroscopic calcification from the ostium left main to the next, please. Extended to the middle portion of the LAD here. Okay, would you show next one? Okay, that one. So the disease extension by angiographic findings, anyway, very diffuse disease, downstream up to the, below the big septal perforating artery. And ultimately, ostial left main is very tight stenosis, and proximal LAD very diffuse calcific stenosis. Would you show us again the aerial caudal view? Aerial. Okay, good. So if you look at the circumflex artery concern, is the ostial part of the circumflex is quite good. However, proximal circumflex there are some disease. No. All right. So the primary plan is actually this is too heavy calcific region. So we're gonna plan road ablation and the FFR for the circumflex, evaluation. That is our, our first plan. So, would you show us this one, the first picture? That is first one. Yes. Okay. So, we took a picture. That one. Okay. Can you see that? Just only for the. All right. This is we took a picture again from the beginning. 우리 이거만 보면 그래서 very much difficult to engage, guiding caster, due to the mainly ostial left main disease, and so ultimately we used the 7 French Jokin 3-5 guiding and for the left main, and then wiring first LAD. And we would like to another wire for the protection of the circumflex. However, our main issue is there are, okay, just a minute, blood pressure is, would you show the aerial cranial view? Exactly same. Okay. So I would just explain what we've done so far. Okay, there is guide is too deep. Pressure is getting full. Okay, so would you show us the first picture? All right. very difficult to engage, even in the engage there, jockeying guiding. And so we've changed is relatively small 3-5 jockeying guider, and wiring for the prox to as main to LAD. However, it is very difficult to wiring circumflex branch, and so we just based on the basic primary coronary angiograms, circumflex OCL part is good. So we are planning to treat first LAD and then main long diffuse calcific region, right? So, all right, limited time, as I'm going to explain some more. Very calcific lesions, even we cannot pass the IVUS guiding, IVUS caster. So we did first IVUS, please. So push, and slowly push IVUS catheter to the distal, and on the mid portion of LAD, you want to have some, imaging to water status inside. That is most important information. So Dr. tells you this different reference vessel diameter is almost 4, very diffuse disease, very big vessel. There are some, 5 to 6 o'clock minimal disease, however, getting more plaque. Reference vessel diameter is big one, getting tighter, stenosis. Okay, it's quite good. Branches, stop it. That is ostial part of, very septal perforating artery is going in, is 6 o'clock. Okay, go ahead. Immediately after, there are really encircling calcium for mid portion of it. The minimal lumen diameter is relatively big, 3.0. However, it's getting tighter. Very tight stenosis, soft plaque, a little bit ulceration. Still more than 200 angle of calcification, superficial calcium. All right, big vessels, more than 4 vessel. All right, this part is in certain part is truly encircling calcium. Minimal lumen diameter is almost 3.0. The circumflex coming in is from 4 o'clock. This is the main distal. Still encircling calcification. All right, so I want to see what happens in this one. Stop it. This is ostial part of the main ostium is pretty much plaque and not, too much calcification inner, and vessel size almost 5, more than that. Okay, go ahead. All right. So there is ostium over the main. All right. So we have quite ideas. By arms inside is very much calcific stenosis, is big vessels, and in some part, just above the septal perforating artery, there are encircling calciums, minimal lumen diameter is 3.0, and a large plaque burden for main ostium too. So very difficult to technically, maintain the guiding. So we did non-compliant balloon dilation from the mid to distal LAD. Would you show that? Okay. Some difficulty to even pass. All right. Balloon 3 non-compliant. Even there are some difficulty. Rupture, the first non-compliant balloon during the inflation. So very tough lesions. We recognize that. So high pressure inflation. Using the 3 or another balloon, high pressure inflation, proximal, even including the ostial part. Actually, we have no other options. Unstable status. Okay, go ahead. So we deploy 3.0 non-compliant balloon inflation. Immediately after balloon inflation, even after the balloon inflation, ostial part main is still, there are some residual stenosis. Technically, it's not easy to fix up, gain the guiding support. And so we deploy the stent distally ready first, 23 and 30. What's stent? Giants, right? 23, 30. Giants, and then pull the, guide in, pull, during the pull, the guide in and the ostial part of the main. Okay, next. And we're going to measure how long, lesion length should remain. So, all right. We choose the longest Giants stent, 3.8 millimeter, from the distal to the ostium here. And 38 millimeters. It's quite difficult to deploy that. Look at that one. So before that, I want to match ostial part with a 38 millimeter stent. All right, this lesion is overlapping. So okay, inflate, and then we're going to do, all right, angiogram here. So personally, I think it's not easy cases. The balloon ruptures, heavy calcification, and so we just fix up the hemodynamic, all these things first. So, and then we're going to do next 35 non-compliant balloon. High pressure inflations in some part up to 28 atmosphere something. Okay, go ahead. A high pressure inflation, almost 28 atmosphere, 35. And ostial part here, spiral view, a little bit compromised circumflex. And so, however, we've seen that even after the procedures. Okay, again, ready. All right. I explained what we've done so far. So I want to take a picture and then explain what we are done. Okay. So at this, after the two stent placement, would you show that? Take a picture. All right. Okay. Picture again. Really? Okay. So. What is that one? That one. I wanted to pick up. Okay? That's okay? All right. Okay. This is immediate after the two stent, high pressure inflation, and we're going to have a obvious. So you explained about, what's happened. So, okay. Would you show us that?
SJ, it's Steve Ellis here.
Yep.
I think there's an impressive amount of calcium, and I think you got a better result with just balloon angioplasty and stenting than I would have guessed. My question to you is, would you have considered orbital atherectomy as a way of decalcifying and preparing the vessel beforehand?
Yes, of course. We at the beginning we want to do the rotablation first. However, first one, so technically it's almost impossible. It's instability of a jockey. And second one, if you look at the IBIS findings, there's a minimal lumen diameter. It's almost 2730 millimeters. And so if you can use 3 over, so the rotablations may have some, effect. However, it is almost, we cannot expect in terms of rotablations, even in the big bird. So I tried the non-compliant balloons.
No, I understand that. I understand exactly why you didn't use rotational atherectomy, but orbital atherectomy would have been an option, although I'm not sure it's all that well defined, its role. I was asking your opinion about orbital atherectomy for a large calcified vessel.
The orbital is not available here in Asia yet. So conventional rotational, so we just cannot pick up the big size. So orbital, maybe Steve can share some experience because 10,000 wire and you can, side debarking. That's in the future. Maybe this one would be a good case.
So since in this particular case, the narrowest site is not heavily calcified. So heavily calcified has enough lumen. So I think there's no benefit of routine rotation.
But I know in Japan is Dr. Saito did start Japan-US combination. We started to have a trial. So orbital just in the trial period.
All right, would you show us obvious? Okay, last part of it. The standing expansion is still, it's quite good. However, I want to show the left main here. Okay, that one. So truly, the ostial part of the stenotic area is missed by, stent coverage. And so I want to, if you look at the angiogram too, there are some, missed regions of ostial part. However, please understand it's very difficult situation it was, and so I cannot. All right, so I want to try really ostial coverage. This is another shot for all sides stent, please. Okay, still.
So SJ, you like to turn to the aerial cranials. It seems to be a more precise osteo left main.
Okay, I will do that. Test, please. Okay, to be honest, we cannot pull out the guiding casters during the second, stent procedure. It's very much unstable. All right, test, please. I think it's okay so far. Spiders, aerial. No, okay, I will take it. That one. Yeah, maybe Dr. Wu want to see this view, tester, ostial part, and would you check that one? Screen, okay. Spider view, also, you can recognize, take a look. All right, picture here. Okay, I will do a little bit further outside. I don't fully coverage of ostium. That is my test, please. Even some part of a proximal stent is hanging out. I think it's a clinical endpoint is quite, not too much. Okay. Oh no, are you? Okay. Okay, test. The morphology is not so good. Early. Test it. I want to take a picture here. Okay. What do you think? This is quite enough, right? Test again. Okay, I'll do that. Inflate. 10. Fasting.
10.
Good. Perfect. 10, 12, 14, 16, 18, 4.3. Okay, deflate. And during the balloon deflations, I want to, pull the guide in. I want to stand inside the stand, and then I want to see that what happened. Picture. All right. I'm sure that it is covered by a stand ostial part. However, still, expansion is not so big, and so I would like to use what about the 4.5?
SJ, it looks like that large diagonal is compromised. Are you going to try to salvage that?
Would you show us that?
Angio 보여주세요. Angio.
Right.
SJ, regarding the calcium treatment, if you using an IVUS and you see that calcium is eccentric or concentric in the amount and the bulk, so this is justify for you to start root ablators or angioscore, shockwave, or non-compliant, because And if you find that you go is non-compliant in one vessel, this justify to the other vessels as well if you don't satisfy with the IVUS results, because you said that in right coronary there is also calcification. So why do you do an IVUS in the right coronary? Do you do the same like what will happen? Because this could be a kind of calcium which differs from one patient to the others. And I don't know, it's amount of the calcium, the bulk, or the type of the calcium, or the eccentricity of the calcium which justify which technique you're going to use.
Dr. Tsang is he's an expert of OCT. Maybe he can make comment regarding the IVUS versus OCT for detection of calcium.
Okay, deeply.
Dr. Tsang?
Okay, just mention, as you mentioned, just diagonal branches has gone. However, we have no. I don't want to, rescue for the diagonal branch. The reason why is that a pretty much, calcific lesion, it's very difficult to do that. And so, picture, okay, still some, we're gonna make I think it's quite enough, standing area itself. However, angiographic findings is still, so we need more expansion depending on Dr. An. Anyway, you mentioned about the debulking. It's good in terms of if we can use a DCA like devices for the ostial part of the manage. Absolutely, sometimes we're gonna do DCA first, and then precalcific lesion. To be honest, by angiographically, in sometimes we cannot pass the IVUS casta itself, and so we're gonna do the road ablation first. And however, we're gonna start with 1.5, sometimes 1.75 is the maximum. Because I don't believe too much about effective debulking, just the breakdown, pre-modification on plaque itself. However, as you see by IVUS findings, as encircling calcium, however, minimal lumen diameter is almost 3 millimeters, and so we cannot use, maximum bore diameter is 2 actually. So I don't expect too much, So the reason why is I use the non-compliant volume first and more easy procedures, and so okay.
SJ,
that is
SJ, do you hear us?
Yes, of course.
Yeah, there was a question of diagonal, and also there was a question of OCT. I thought I saw pretty tight stenosis in the diagonal. And what's your plan? Are you going to go after diagonal now, or can you show us the diagnostic setup shots?
All right. Show us again. All right. Would you show us diagnostic angio first? All right.
Opposite to the septal, there's originally they have 2 millimeters in size of osteostenosis. So it's a sizable territories also. So the question is, do you like to rescue that diagonal or not? Is the patient a symptom or not?
No. Currently, patient didn't feel too much about chest pain. However, in terms of those conditions, I want to do just wire protection if possible. So I don't want to fix up the diagonal branches. You know that there are heavy calcification. I don't believe we know perfect things. And so, however, technically, very difficult to wiring, even in wiring LEDs, even in wiring diagonal branches. And so we do just the main procedures, LED stenting. So there is benefit and losing point. And so, okay, I'm wait for a while. So nitro please, and then.
SGK, this patient has silent ischemia in 78 years. So what are the indications of complete revasc for such a man?
Complete revascularization. All right, I understand. However, it is big territory vessel that must be treated. However, there is relatively small branches, stenosis. I think is optimal medical treatment is quite enough. So, to be honest, this case is very tough one. Totally at the beginning we didn't expect this one. So, all right, from now on, so we're gonna do IBS again, and I think it's 375 high pressure, non-compliant inflation. On the mid portion especially, we have already, lose the diagonal branches, don't care about that one. 3.7 high pressure, 4.5, and up to 5 something, right? We can get us more effective scenario, right? All right, Dr. An, Dr. Kim, Dr. An will give us some part more, and after the Alan Young, the case, move to the Alan Young cases, and the final result you want to show that. And so I think this is the last cases from the Asan Medical Center and coronary theater to the coronary theater. I have to move to the pelvic theaters, and so I would like to say goodbye here, and really thank you for coming, and faculties and attendees, and we are very exciting, happy to have a lot of you all, and maybe next year's meetings we want to have a more solid and good we're going to organize a good program, and so possible. So see you next year again. All right, thank you. Right, you want to do cases for more?
Thank you
If
very
I can
much.
make just quick comment related to OCT. In my practice, I use intravascular imaging as 70% of my PCI, 90% OCT, 10% IVUS. This particular case, I would have used IVUS because there wasn't really no reference for left main, and with OCT, you have a problem of finding reference.
The question in these calcified lesions is twofold. One is the extent of calcium. Is it circumferential extent, yes or no? And the second question is always, is calcium protruding into the lumen, which typically makes all the balloon rupture? And I think both questions can be nicely answered with invasive imaging. The advantage of OCT in these lesions is that we can also assess the thickness of the calcium, which also gives us an indication how much lesion preparation we might need to modify and being able to extend the plaque. In this situation where the ostium needs to be assessed, obviously OCT is not very suited. I agree on that.
Okay. Let me move to the next case. Maybe SJ Park was very busy. Okay, Alan.
Hello.
So, hello, how are you?
Hi, Steve and Dr. Tak and the panel. I'm here today with Dr. Lee and Dr. Yun, a great team, and actually Dr. Lee has laid out everything already. I'm just here to help him a little bit, putting the stents in the next few minutes. So Dr. Yun is going to tell us about the case first.
Yeah, I'll introduce this case. This patient is 61-year-old male, was hospitalized for non-ST elevation MI 2 months ago. Following angiogram showed left main disease plus mediated LAD, and this is circumflex disease. And also RCA disease was so tight, so we performed RCA PCI first at that time. And the FFR value for mediated LAD was 0.74, so we decided to perform another PCI at left main to 880. And he has no other past medical history. Next. And he also has diabetes, hyperlipidemia, and clinical presentation was non-ST elevation MI. Next. And echocardiogram showed RCA territory ischemic insult, and with preserved alveolar systolic function. And next, and Alan.
Yes, so maybe we can review the angiogram from today. We talked about the FFR as well. So this was the FFR from last time.
Yeah.
And the number is 0.74. And I think Dr. Lee and the team also did a pullback. There seems to be some gradual increase in the value, so meaning that seems like it's a bit of diffuse disease in the LAD to the distal left main. So that's the FFR. You can see the angiogram today. So there's some haziness in the distal part of the left main. The circumflex looks reasonably open, the origin at this view. And then there is disease in the distal circumflex. The large OM branch has a pretty tight lesion. And then this sort of centered has a sort of a subtotal area. So the right coronary is very large. So our thought is just to leave that middle one alone for now. Next view. So this is an 8 French guide JL configuration. You can see there's a very large, almost a parallel LAD system with the Ramos intermediate there, and then a 90-degree angle coming out to be the circumflex. And you can see the tight OM branch in this view as well. Next. Next. I think that's all we have. And Dr. Lee has expertly wired them all and also has performed intravascular ultrasound in all 3 branches, the circumflex, the Ramos intermediate, and also the LAD. So maybe we can start with the circumflex?
Yeah. Circumflex.
Circumflex IVUS. So this is coming back to the distal circumflex. You can see some calcium at about 11 o'clock. And as it enters the LAD and the Ramos, you can see coming in together. There's some plaque in the origin of the circumflex. And I think you measure the area. Right? Can you see it? You can see it. That's great. So 5.03 as the lumen. Plaque burden is 54%.
Yeah.
Okay, let's take a look at the Ramos intermediate pullback.
Yeah.
So this is the pullback. And quickly you can see that the LAD and the circumflex will come in a moment.
Yeah.
So that's a lumen area of the Ramos intermediate, almost, again, parallel LAD system.
Yeah.
So that's pretty big, 8.
Yeah.
Let's look at the LAD. So coming back, and you will realize that there's a pretty diffusely diseased LAD. Plaque burden may be, between 30 to 50% maybe here.
Yeah.
Lumen is still not bad. And then becomes a more normal area. This area is relatively disease-free, so if you want to treat with one stent, maybe an area to land in.
Yeah.
Then it gets a bit more bulky.
This is proximal LED.
This proximal LED now.
Yeah.
So pretty soft plaque most of the time.
Yeah.
And now this is the close to the origin, coming up soon. There's a septal coming, right? There's the big septal. So a little while still to go. So quite a bit of plaque burden, but the lumen is not very compromised, so I can see why the FFR, when you pull back, is kind of a gradual increase in value. So it's coming to the ostium with the Ramos coming in first.
Yeah.
And then the circumflex Y coming in. There's plaque clearly in the distal left main. This is probably the tightest area of the left main. And it's come back, there's some plaque. Probably we want to put a stent, maybe end up about here. We don't necessarily have to take it to the origin. So So that's the guide.
Could you measure left main?
So left main measurement. This is, you think this is the smallest area, maybe?
Yeah, just the left main in the 4.68 millimeter square, and plaque burden is 80% in the just distal bifurcation, proximal portion.
Yeah. So just to summarize, I think from the angiogram and IVUS, the circumflex origin has a bit of plaque, but the lumen size is still pretty good in the 4s. The Ramos origin looks pretty cleaner. The LED is diffusely diseased and pretty much the whole proximal LED, and then the tightest area is the distal left main. So we think if we want to go from normal to normal, which is on this angiogram, maybe go back to the angiogram. If we want to treat completely normal, it has to go to the distal to that diagonal, to that little septal, and we measure the distance, it's 60 millimeters.
Yeah.
But if we want to treat somewhere in between, then it's probably a 38 or 32. So I think the technique that we are thinking about is relatively, hopefully straightforward. It's just putting a stent from the left main to the proximal LED, and then we see what it looks like in the circumflex and the Ramos, and then decide whether we need to do what else in the LED distally, and also what kind of post-dilatation in the proximal LED left main. So that's kind of the strategy. So any comments so far?
Can I see the spider again? Spider
Can you spider view, please?
Spider.
I think there is a involvement in the ostial CX, which is evident. Distal left main to ostial CX. So what you are going to do?
We're just going to protect it in provisional for now. Just do the proximal LED left main, and then we'll see what the circumflex looks like. Because from IVUS, it doesn't look like this too tight.
Yeah.
And therefore, in the circumflex itself, we actually want to fix the distal lesion first, because once we put a stent in the left main, it's more complicated, obviously, to fix the circumflex. So we did that already when we came and we can show that to you.
Alan, what's your distal landing zone? Because they have some insignificant disease also in the LED mid portion. So where you want to land your distal stent?
We measured a few times, and we think it is just about a few millimeters beyond the big septal branch. If you play the angiogram again, because obviously we can fix the distal one first, but I want to kind of fix the proximal LED first. Because distal, that's disease, but it's not critical disease.
Yeah.
And if we need to stent it, I think we can pass the stent through the left main stent and distally and overlap minimally there and be able to fix that distal LED. But I might feel that, maybe there's nothing to treat as well.
So Alan?
So let's show the circumflex, maybe just so that we can catch up to.
Alan, I'm also a little concerned about that circumflex in the caudal view. How did that stent go when you were going around through there down to that
pretty
LM?
easy.
Okay. I think that tells you something as well.
Yeah, so that's why I want to go with the balloon and the stent, just test it out first and see how that feels. And it feels pretty good. Obviously, a French guide, but it's a JL configuration. So that's kind of how I sort of approach it for now. It's obviously not trying to do a two-stent technique here because there's not enough disease in the circumflex to go do a two-stent technique. Yeah. Another thing I was thinking about coming over, without seeing the angiogram yet, sometimes we have done this FFR. If we have an FFR open here, we might put the FFR in the circumflex and trap it behind the stent, and then actually do an FFR after we put the stent and be able to tell physiology right away without having to rewire the circumflex, because that's always hard to rewire circumflex with an FFR wire. But the wire that we should use is the Boston Scientific wire, probably better because it has the optical sensor for the pressure and has less drift. So one times when you're doing some of this stuff, we leave the FFR wire in for a long time. For example, St. Jude valve, there's a fair amount of drift, and then at the end you don't know what is real and not real, and that may be actually more of a headache than helpful. Okay, so I think it's the stent size. We thought maybe Dr. Lee?
3.5, maybe minimum lumen the distal landing zone in just beyond the septal point is maybe vessel size around 3.5, lumen is the 3.0, and proximally the left main size is 4.3. However, lumen size is 4.3. So we want to choose the 3.5 to minimize the damage of the distal landing zone.
Right, and then we can always make we could use a synergy stent. We can always make it bigger to close to 475. So I think we can do that.
So let me go back to regarding to the distal landing zone. So as you see it in the pressure curve and angiography, maybe if you put the stent around the first septal branch, maybe FFR after stenting is not optimal, maybe less than 0.9 there, because we have another not severe but relatively long segment of disease distal to the stent. So maybe we can consider the longer stent to cover the,
Right, so the longer one we measure to 38 is actually end up in a zone that may be even more disease. So it's a compromise, and again, I think if you want to stent the whole thing, you can put 2 stents in pretty easily. So it's 60 millimeters, so we thought we can put the short one in first. So let's open up a 3.5 32 synergy stent. And let's see how, since we're kind of trying to concentrate on the left main, see how the left main circumflex origin reacts to the stenting. And then we can deal with whether, we do an ultrasound afterwards, take a look at the distal LAD. Did we miss any area? If so, we can put a second stent through the first one after that. Is that okay?
Another option could be to have a look at the longitudinal IVUS view. Some authors suggest that the eyebrow sign, the protrusion of the carina into the vessel, has a predictive value for carina shift and jeopardizing the ostium of the side branch.
That's a good point.
Okay, cranial?
Yeah.
So why not use a 48.3 for the LAD, and then the rest to be the left main with 3 to 3.5, and then pot and recrossing and see what's going on the oslet sex. Because if you go the left main LAD first, and then you go to see the rest, it's not so easy like you do from the distal to the proximal. It's not so urgent left main to do that. So what's your policy to make it the proximal first?
Yeah. Picture.
Okay.
Okay.
A little bit pulling out. Test it.
Test. So this is, just to have an idea how long this thing is. I think we can certainly come back a bit and cover a bit more left main, and then end up in the area that we were thinking about is just that little bit more of a disease, still disease, and maybe we can have a little bit more normal area there. Maybe test it.
Test, please. A little bit.
Pull back a bit. I think that's good.
Okay. Test it.
Test.
A little bit.
A little bit more proximal, I think. Okay, let's see. Test again?
Test again.
More.
A little bit.
Yeah, good. Okay, test.
Test, please.
Yeah. We're still kind of distally in an area that is really quite diseased, unfortunately. So we're going to try to see if we can pull the left main back, or pull the stent back a bit in the left main, because I want it to be a little bit more proximal.
Okay, that's good.
Test.
Test. Yeah.
Let it guide in a little bit.
A little bit pulling out.
Yeah. Okay. Okay, let's take a picture. So 32, it's end up a little bit in that area of disease there. So I'm going to pull back a bit more, because I want it to be a bit more in the slightly wider area in the LAD.
Yeah.
I'm going to get the guide out a little bit.
What
this is just a fine point here. It's like, we're trying to avoid, maybe don't have to stent distally, but
test it.
Yeah.
What is the reason why you go to direct stenting instead of pre-dilation?
Because it doesn't look that tight in any particular area.
Looks good.
It's good. Go ahead.
Okay. 11. Slowly.
It's a plaque there. You can see. Yeah, I mean, I normally dilate the the left main and get it open a little bit. But it looks like pretty soft plaque and pretty focal disease there. So I decided to go ahead and just do that. Okay.
Okay. A little bit.
Come back a little bit.
Okay. Okay. 10, 12, nominal 12, 11.
Yeah, that's good. And then we can evaluate. Yeah. So we're going to nominal for now because we just want to take a look at how the circ reacts. This is good, the more caution way of doing it. Okay.
Yeah. Okay.
Coming up.
Okay.
I know that many of us will probably do a little pre-dilatation, but I think here is probably okay to do that. And not much calcium. If there's any calcium, I would pre-dilate so that we can have a good expansion of the stent subsequently. So maybe a little nitro?
Nitro, yeah.
So we're going to go back with maybe take a caudal view of angiogram and see before we do an IVUS in there, see what it looks like. The caudal view probably shows the worst.
Just a moment, just nitro, okay. Done, go.
Okay. So we're going to take a picture in the caudal view.
Okay, just a moment.
Get my guide in a bit.
Just a moment. Okay. Okay.
Ready? Okay. Picture?
Yeah. No, not bad.
This looks pretty good.
Yeah.
Spider view, maybe?
Yeah.
It obviously pinch a little bit, but I would say that if we have an FFRY, there will be probably not significant. Ready?
Okay. Yeah.
Looks
good. Looks good.
So let's do an IVUS of the LAD because that's what I'm more concerned about, is how much disease distally we're leaving behind.
Alan, it looks like on the expanded. Would you not dilate first and then IVUS?
I actually want to take a look at the distal area first, just for fun. See where I land. Because also it's only 10 past 12. Can you go back to the AP cranium?
Yes.
So IK, if you don't want to do high pressure, do you usually leave all the wires on the side or you just take the wires out?
Oh, before high pressure, I put the wire out.
Yeah, I think even though, most of the time these wires, these are all Xeon wires, they should be fine, but I think...
Okay. Okay?
Yep.
Okay. From mid-LAD, normal, completely normal.
So that's a good area to put a second stent distally if we need to. Looks nice and clean there. But there's some plaque there now. But the lumen is still pretty good.
Yeah.
I cannot see FFR being positive here. They're all about 4. That's the diagonal, maybe?
Yeah, diagonal. Yeah.
So that's the diagonal. There's a little bit more ectatic area, a little bit of an athro, big lumen.
Yeah, pretty good.
And then we'll come to the area probably relatively the smallest of the leftover stuff that we try to avoid not stenting.
Yeah.
This area.
And maybe start from here.
That's just plaque, yeah. So that's good. We don't want to stent in there. This is a bit more narrow area.
Landing zone is good.
So acceptable landing area if you don't want to put any more stents in. I'm not saying there's a little bit of plaque, but it's not bad. Actually pretty good diameter there. Obviously proximally would be expected to be underexpanded because of no pre-dilatation and also obviously the bifurcation area. Obviously, we cannot judge the side branch that well with ultrasound, but here looks the Ramos has always been good, and I think the circumflex looks good as well in terms of the opening.
Yeah.
Because the plaque, again, on the opposite side wasn't too much around encroaching the origin. This is now the left main. We'll see what size balloon we need to touch up on the left main. Actually expanded quite well. It's kind of bigger than I would thought it would be.
Exactly.
We were right at the origin. Yeah. Pretty good. We haven't taken a view here to see angiographically how it looks like, so maybe we can take a picture. So maybe the panel, you can discuss, maybe help me what we think should do next. Anything to do in the distal LED. Let me take a picture for you.
I would stand the distal LED. I would stand the distal LED and then do a pot and recrossing and final kissing and see what will be the result of the osteoCX.
Okay. The opposition maybe requires 4.3, maybe 4.0. 4.0 balloon is okay. Yeah, 4.0 balloon.
So, panel, should we fix the distal LED?
So on angiography, and I've studied, maybe it is not necessary to do another procedure to the distal stent, but maybe if you have time, would you like to show us the result of study of FFR?
Okay. So we'll see whether we have time and see whether we can change over to FFR. Before that, we should probably post-dilate. But I heard that there was a comment about rewiring the circumflex, open it up, and do kissing. We don't do that here in Asan.
Absolutely.
I think we just, I like the stent to be natural, that it covers the most important part of the vessel. And the side branch on the 3.5, once you open it up, it's pretty good hole. So there's no need to distort the stent. We'll do that's sort of a part. We can use a 4.0, open up the, but I would probably at this time remove the wires from the side branches because it's kind of in our way.
I think one of the concerns is because you know that the obtuse margin is sizable and you have a critical stenosis also. Very distal circ also they have subtotal occlusion. So in the future you want to treat, of course you do a part, wiring is not a problem in the future. For the patient after this procedure still have some symptom, maybe you need to fix the circumflex. That is a more concern regarding you fenestrate the circumflex osteo.
Yeah, I think so, but at the same time, we fixed the one of the big OM. The little branch in between, I understand, we want to fix everything, make it perfect, but I think here it's not worth the time and money for that circumflex, the little branch. And again, you're paying the price of distorting the left main stent, which is the more important vessel. So I agree that there's one approach. So I'm going to take the wire out for the...
Yeah.
Do you think that you said in the echo there is akinesia of the inferior wall, so the circumflex, the two OMs circumflex are so important rather than the right coronary? So we agree that it's very important to make complete revasc of the CX, both the distal CX and all obtuse margin, either now or you can make it on staging procedures after doing another thallium or a cardiac MRI.
I think he had a non-STEMI. I'm not quite sure whether it was a STEMI. So I think first thing of order is actually to follow up on his right coronary, his ventricular function, whether it's any better over time.
This is maybe reasonable complete revascularization because of the distal circuit. Not so much.
So we have our resident CTO expert at Asan. He said basically he's not going to spend time on that circumflex. So I think we should leave it alone.
Let us go back to the previous case briefly, and we will come back again.
Sorry, can't hear you.
Dr. Bach,
Dr. Bach's case.
Oh, okay.
Let us
All right,
go back
okay, thank you.
No, we'll come back.
We will come back within 5 minutes, okay?
Hello.
Dr. Han, would you like to explain the final result? Maybe you open the side branch instead of SJ Park.
Yeah. Okay, long please. Angio, please. Okay, long please. So, fortunately, I can insert the wire to the side branch. So this is the Seoul wire, and then several attempts, and then.
So you didn't use a Crusade double lumen microcaster, so a very super technique. Because sometimes
thank you.
Japanese colleagues, they will do a Crusade routinely double lumen.
Oh, really? But anyway, next I successfully insert wire, and then I apply the 1.5 initially. Next 1.5 5 balloon. And then I changed to wire to the upper diagonal branch. I think upper diagonal branch is bigger than lower. So next, this is a 2O high pressure balloon, so calcified lesion. So I used the high pressure balloon, 2O 20. Next. So this is immediate after high pressure ballooning. Next. So I applied the kissing balloon. This is simultaneous kissing balloon. This is the LAD high pressure. Next. Side branch high pressure. Next. Both kissing balloon. This is immediately after kissing balloon. So I like to remove the whole wire and check the final angiogram, and then I like to finish my procedure. Okay, let's see. Ready? No.
Yeah, this is usually the osteo, how the osteostenting is, you lose the wire, then you might lose the guiding coaxial.
Okay.
So this, the next time,
Ready?
the fellows have a difficult time to engage the lemon because so much protrusion. How long the protrusion is from the IVUS view, from the lemon osteo?
Can you show us the IVUS rest test? Okay. It's my mistake. Test it. Okay, ready?
Yeah.
No. Ready?
Ready?
I can see, but we check the IVUS. Could you show us the IVUS? This is the final IVUS. This is the can you show us the left main? We applied the 4.5 high pressure balloon up to 24 atmosphere. And this is ostium, 1 or 2 millimeter, or maybe 3 millimeters. So I applied 4.5, very expanded stent minimal diameter is 4.5 at least. So so I think even though very calcified LAD disease, using the very high pressure, so we can achieve the very enough large minimal stent cross-sectional area. I think
to get the optimal result, we cannot avoid some protrusions. I think it's quite good result. Congratulations.
Yeah. Thank you.
Yeah.
We can save the side branch as well.
Also, congratulations saving the side branch.
Can you show us the final angio?
I guess from this case, educational purpose, because this is not a beginner's case. At the beginning, because I didn't have a time to ask SJ regarding the syntax score for this 78 years old gentleman, because in terms of PCI, of course we can do this kind of lesion in the experienced hand, but however, this is not definitely a beginner's case. This is tough, needs think about it. So for this case, maybe in the Western, US, maybe will consider to go for surgery. That's the educational purpose.
Yeah, I fully agree with your opinion. And this is also a very good candidate for surgery. Thank you for your comment.
Thank you, Ann. Thank you very much. And let us go back to it. Yeah, Lan, come back. Can you hear me?
Yeah. Now let me come back.
Oh, okay.
Yeah.
Hello.
Yeah, hello. Hello. Oh, your earphone is.
Sorry, my plug fell out. Earplug. So we dilated the proximal LAD left main with a 4.0 up to 24 atmosphere in the left main, and now we're doing another pullback of the LAD, and we're just in the middle of pulling back, so maybe we can share with you. Clearly, there is a lesion distally. Whether we can still trust IVUS and measuring at M MLA, or we think we need to do an FFR, or we need to just put a stent in. So we just mainly looking at the left main.
Alan, just one more option is you can do OCT, and if there are OCT predictors of rapid progression, then you have lower threshold for PCI. If it's purely fibrotic without any evidence of rapid progression in the near future, then you want to be more conservative.
Yeah, that's a good point, IK. So maybe we can show the live the IVUS. Oh, you have it there, yeah. So we're coming to the left main area.
Okay.
We can play back for you.
다시 보여줄래? This is most tight portion before treatment.
Alan, it looks like that mid-LED lesion is going to be 4.5 square millimeters or so.
Yeah.
And at that location, it's probably
can show
sufficient.
the most tightest portion of the non-static segment.
It's smooth. I agree with you. I try to leave it alone.
Yeah, this portion. Yeah, could you measure?
Yeah, so this we're going to measure the MLA there.
Largely.
6.1. 5.3. Let's see. We'll finish it up.
Oh. Minimum lumen area 4.5.
I think it's smaller than that.
Yeah, take the 2 o'clock in a little bit.
Measure the H-pi large.
I think that's okay because there's a little bit of sort of blood, So I think, obviously if we do physiology, do imaging, we usually leave behind lesions that may not be so sexy, so pretty.
Yeah.
So the question I think we have gone away is mainly that now is fixing the most important physiological part. If we have time, we can certainly do an FFR, but obviously it's costly. Once I do using one imaging modality, I try not to use multiple ones because it is just expensive to keep opening up different modality, especially in the States. Some of it is not reimbursed well. So how about left main? How does the left main distal look like?
The most tight portion in before treatment.
So this is just distal left main right here, right?
I can one of the question regarding the opposition because OCT definitely can see more clear than the IVUS. But the clinical results showing the head-to-head comparison with lumens and some other studies doesn't showing such clinical relevance using OCT to detection some malposition. For this case, left main, I guess there was some mild malposition if you use the OCT. But what about the clinical relevance?
No clear evidence-based statement that OCT is better. In recent study, as you know, opinion showed equivalent. So other than some additional information, either should be fine.
There is
it's
also
not heart-shaped,
a number of studies coming out of Japan showing that malapposition in the range to 350 to 400 micron typically is resolving over time. So this per se is not a problem, but we should not forget the extent of the malapposition and the length.
Let them finish. So we measured the left main area is 15. So that's the smallest area. So our feeling here with the team that basically felt that we can leave the LED alone. Meaning traditionally when we use IVUS alone without FFR, we'd say any part of the LED, even proximal, is 4. So we have about 5 in the mid portion. And remember, he has a very large Ramos branch. It's a parallel LED. So after this LED, except the diagonal, there's no more branch. So I think just by integrating the angiogram in terms of the branches, that I don't think this position needs to be very large. So 5 is good enough, and I think that's where we stop it to be. And I think more metal is not always better, so overlapping, and I think there's a diagonal branch which I don't think would be compromised. So given that he has a very large Ramos, I think we should stop here and leave it alone. Dr. Lee?
Totally agree.
Okay. So we are going to conclude, and thank you very much for all your opinions. I think it's kind of a not too complicated case, but helps us figure through all the measurements and all the different, if we have OCT, I think that's also another way to measure how long, where do we land. And I think overall that the angiographic pictures looks very good. I think we also argue about whether complete revascularization is important. You can see on this view that occluded middle part of the circumflex is sort of the AV groove vessel. I don't think it's worth the revascularization time and money. We fixed that first OM. So basically now his right is fixed. It was a proximal large right. And I think his ventricle may improve. I think we were just at a time when he was having an MI. Circumflex is taken care of, and the left main LED is taken care of. So let's see clinically how he does and go from there.
I hope the maybe outcome is very nice.
Yeah. All right. Thank you very much, Steve and Dr. Tak and the panel.
Thank you. Thank you very much.
Thank you for an excellent demonstration.
I will finish.
Okay.
It's your time?
Yeah, we have a little bit of time.
Yes. Things in the case if we go to the physiologic study, the purpose is not to determine that there is ischemia or not, to measure post-PCI FFR, and that represent the degree of residual disease not treated, maybe correct with the prognosis based on the.
So I think there are really two components to a post-PCI FFR in this case. One is how well is the stent expanded, where there's data, some data to suggest that FFR is useful, and then in this case there's the residual disease that's distal.
So the total is residual disease burden, and maybe we can pull back and measure the trans-stent gradient through the stent. That means overall under expansion of a stent. Yeah.
I suspect the FFR would have been fine. I mean, not normal, but fine. Yeah. I wanted to ask IK to elaborate because we're very. In these days, we're very hemodynamically focused for FFR, for instance. But you made the comment that there are some potential predictors of rapid progression by OCT, and I thought since you brought that up and we have a little bit of time, maybe you could elaborate. How good are they? What are they, and how good are they?
So, Dr. Shiro Uemura, he published in European Heart Journal. What he did was he did a baseline angio and then follow-up angio. When there was more than 30% progression, then he went back and looked at the plaque characteristics of those with rapid progression. And he found two predictors. One is TICFA, and the other is microvessels. So neither one you can detect with IVUS. So if you want to predict rapid progression, you have to use OCT. Whether there was another study or prospective replication of the data, answer is no. But that's pretty solid data.
Regarding the distal edge of the stent here, in this case, I'm suspicious about this. How do you prove that this will not develop new atherosclerosis by OCT or IVUS? Maybe FFR at that time would be 0.8 or 0.75, but still there is in this distal end of the stent with the shear forces can produce in the future. So how can you convince yourself that you leave this patient with such an good FFR but suspicious of new atherosclerosis by IVUS OCT?
So, it's a matter of probability, and we also published, I wrote an editorial in Circ Imaging a few months ago. So with the contemporary medical therapy with high-intensity statin, about 70% of the plaque with a 6 month and then 1 year, there is a regression, significant regression. About 20%, there is rapid stepwise progression, and about 10% slow linear progression. So 10% slow linear progression probably through a smooth muscle cell proliferation. We as interventionalists, we don't care too much. We are not too worried. If they come up with a positive stress test, then we stent it. What we are really concerned is rapid stepwise progression. Those are the ones who come in with acute coronary syndrome. So about 20% with contemporary medical therapy, high-intensity statin, they still do develop this rapid progression. And what are the predictors of those rapid progression cases? And those two that I mentioned, TICFA and microvessels. That makes sense. TICFA, one of the two mechanisms, one is rupture, the other one is erosion. So they develop mural thrombus, organized, and then rapid progression. microvessels, red blood cells go into the plaque, intraplaque hemorrhage, either rapid expansion or red blood cells had a high cholesterol, so initiate whole inflammatory process. Microvessels, that's the case, and TICFA, disruption of thin fibrous cap, mural thrombus, which may be subclinical, but will still contribute to rapid progression.
All right, other commentary across the podium here that's relevant to this case or what we've been discussing? All right.
I have a question again regarding the calcium. How many patients with calcium develop infarction rather than the hard plaque or soft plaque? I mean, if you do debulking and put a stent and leave a part of calcium, did this mean that the same like leaving a plaque? Because I didn't see usually a frequent myocardial infarction with calcified lesion, usually with a plaque ruptures. So how can you?
So I think the general adage that calcified vessels are somewhat more stable, but I'm not the best to answer. Evelyn, do you want to comment, or somebody at the podium?
Yeah, I can make comment.
Okay.
Sorry. What really matters is what's called microcalcium. The size is between 5 and 65 microns. So IVUS unfortunately cannot detect, but IVUS can show so-called spotty calcium. That's right. And we did pretty thorough literature search. The definition of spotty calcium, either with IVUS or CTA, is very vague. There is no clear definition. So microcalcium is not easy to detect, even with OCT. So, and we compared every possible calcium patterns between patients with STEMI caused by ruptures, so extreme case, and then we got another group, stable angina, and try to compare any calcium pattern. We measure every possible shape, the distance from lumen to the first leading edge, zero difference. So how much calcium contribute to plaque vulnerability is totally unclear. And as you know, if you treat patients and plaque with high-intensity statin, calcium score does increase. So far, the beginning microcalcium will contribute through probably a mechanical contribution. But advanced is an indicator of advanced atherosclerosis. And whether that's a sign of plaque vulnerability, probably opposite. It's more stable advanced plaque because statin will increase calcium.
Okay. All right, excellent. So I think I'd like to thank the people at the podium, the audience for being patient. I thank the operators, except they're not here, and I hope you enjoy the rest of the meeting.